All right, I think we're about ready to start. I did want to let you guys know a little bit of a background for the technology we'll be using today. So we are using the Zoom webinar platform. And for anyone that hasn't been on one of Health Insight's Learning and Action Network webinars, it will be an interactive call where we're going to turn things over to you, the audience, during certain times today. To reduce feedback noise, everyone right now is and will remain on a global mute throughout the presentation. We ask that you do utilize the chat box that is circled here during the presentation for any comments and questions. You'll find that chat box by clicking on the chat bubble icon, bubble that looks like one pictured on the slide here. Following the presentation, there'll be ample time to answer any questions you may have. However, like I said before, please feel free to chat your questions in throughout, and we're going to collect your questions and respond to them at the end. And during the question and answer phase of the webinar, we'll ask you to use the raise your hand feature located at the top if you want to audibly ask your question as opposed to using the chat. And this will allow us to keep everyone on mute except you during your question. And finally, questions that we're not able to get to during the actual webinar, we will we'll follow up with everyone following the presentation. And then one question we always get is whether the slides will be available and whether it's being recorded. And yes, it will be recorded, and both the presentation audio and chat features will all be available to you shortly following the presentation. At the end of the presentation, I'll also post a link to a survey, and it would be really helpful if you would take just a minute to fill out a few questions on there. It will help everyone presenting today on their journey toward improvement, and also allow us to bring you the best education we can in the future. So without further ado, I'm going to talk a little bit about who Health Insight is. Okay, so who is Health Insight? We are the regional Quinn QIO, which is the quality improvement organization for 4 states. So for Oregon, Nevada, New Mexico, and Utah. And we're a private nonprofit community-based organization, and we're focused on a number of different measures, obviously including behavioral health for Medicare Part B beneficiaries. I wanted to give before I make introductions on who is going to be presenting today, I did want to provide a disclaimer. So the material that's presented today will be done so by the regional MAC or Medicare Administrative Contractor, Noridian, on Part B claims. If you're an FQHC or RHC, which I know there are some of you on the line, you'll likely be billing Part A a lot more than Part B. Noridian has quite a lot of resources around Part A billing that is not going to be a part of this presentation, but the Part B information it will definitely be helpful to you as well. And we're happy to share those resources that Health Insight, HSAQI, and Noridian all have onto you following the webinar if you so need. Also, as Noridian is the regional MAC, if you're not in their jurisdiction, if you're in another MAC's jurisdiction, there could be some nuances on requirements for billing that you may want to check with your local MAC on. And if you need help figuring out who that is, please let us know, and we're happy to help you figure that out. So next slide. Okay, so again, I'm Christopher Wells. I'm a practice facilitator and project manager with Health Insight Oregon, and I work specifically around behavioral health, but I also work across tasks on our cardiac health, diabetes care, and self-management, also care transitions and immunizations, to name a few. And Lori Weber, who's with us today, is the current Idaho, Oregon, Utah Provider Outreach and Education Representative for Noridian. She joined Noridian, the current Medicare Part B contractor for 13 states in 2006. She's also co-chairman of the Idaho Healthcare Conference and board advisor at Carrington College. And she loves the topic that she's talking about, and I know is really excited to educate everybody on the line so that we can start helping as many of our beneficiaries as we can. Like I mentioned, we also have a representative from HSAQI on the line, so I wanted to go ahead and allow him to introduce himself and introduce who HSAQI is, so that we know who all is on the line. So I will let Dave take it from here.
Hi, good morning. Can everybody hear me? Chris, can you hear me?
Yeah, we can hear you, Dave.
Okay. So yes, good morning, everybody. This is Deb Ashish, Dave Mitra. I'm the Executive Director for Health Services Advisory Group in California. And next slide, please, Chris. We are the Medicare Quality Improvement Organization for the state of California and Arizona in the Western region, part of the Noridian network, and also for Ohio, Florida, and the U.S. Virgin Islands. So the purpose here is just to have a couple of minutes introducing HSAQI. In California and Arizona, we provide a whole gamut of services, next slide, for Medicare service providers, which includes physician offices, hospital, nursing homes, etc. And the purpose is to improve quality of service. And part of what we are doing here in California and Arizona is improving, next slide, the resources and just kind of, we're one of the largest QIOs covering 25% of the nation's Medicare beneficiaries in these 5 areas. Next slide. And how can we help you? So next slide is specifically this webinar is targeted at improving the rate of behavioral health screening, which includes depression and alcohol misuse screening. And we have certain resources to help support providers that work with Medicare, billing Medicare Part B fee-for-services in improving the rate of screenings. Why is it important? Because it does play into primary health care, with the maintenance of primary health care, and mental health is an issue. So especially in the Medicare population, so we are trying to make sure that they are screened and are identified for follow-up services. And the other benefit is that Medicare does have a separate billing codes for reimbursement of depression and alcohol misuse screening, and then follow-up counseling if there are patients or Medicare beneficiaries that are identified as risk. So that's definitely, when we look at the statistics, we find that a large percentage of providers, they may be doing alcohol and depression screenings, but they're not claiming reimbursement from Medicare. Next slide. And apart from that, we also provide the quality payment service, quality payment programs, technical assistance support. That's again no cost to the provider. All our services are provided at no cost. And we have a fully staffed service center, which is operational 12 hours a day, where you can call in with your support questions, any kind of issues you have with quality payment program, and we have technical trained staff to assist you. Next slide. And this is just the contact information, and I'm sure, Chris, you're going to probably distribute it. This is for Arizona and California. If you have any issues with any Medicare services, you're encouraged to call us, and we'll definitely help you to the best we can. Thank you, Chris, for giving us the opportunity, and over to you.
All right, great. Thank you, Dave. So, yeah, before I introduce our, or have Lori, who I introduced to, take over and do the meat of our presentation, I just wanted to go over, or ask actually who we have on the line. So, like I said, this is an interactive environment. So we really want you to be comfortable asking questions, since we have some some really great people online that can answer it or provide you a place where you can find it. So if you could, if you don't mind, if you're on the video version, please type into the chat your geographic location, and if you don't mind, also your position within your organization. So whether you're the provider, a single provider, or a provider in a health system, you know, and or biller, MA, office manager. And I'll give a couple minutes to I see some people coming in. Great, thank you. And a couple more minutes to do that. It looks like we have quite a bit of quite a few office managers from across the state, which is great. It's, I'm glad that this has been an elevated conversation to that level because it's very important. So so thank you everyone for chiming in. Continue to chime in so that we know who all is on the line. So so feel free to keep doing that. Thank you. And just a little brief information on you know, the current status of where we are for Medicare beneficiaries and older adults in general. So, you know, alcohol and depression, you know, the percentage of older adults who die from alcohol-related deaths each year is about a quarter, and that's a staggering number, and that's a number that shouldn't be that high. You know, it shouldn't even be 1%, but a quarter of the population is astronomical. And you know, the number of people that are suffering, of older adults suffering from depression, is over 2 million in the United States. That's a huge number as well. So, you know, I'm hoping that, you know, while I know that a lot of people in the registration that we sent out earlier on said that they are conducting screenings, they just may not be billing for them. I hope that this is also able to help people that that may not be screening as well, that could start screening, because there are a few people that were in that category, and I'm hoping that after this webinar that you see the utility of doing so. And this might be a little bit small, but I'll, you know, the majority of people probably know what this is. If you don't, then let me know. I can go ahead and send this to you because it is public domain. But these are two examples of the depression screening. So the PHQ-2 and PHQ-9. The 2 is given sometimes as a precursor to giving the longer PHQ-9 version. A lot of people just skip the PHQ-2 and go straight to the 9. I've seen that quite a bit, but both of these will help you in the process, not only for finding out the symptoms of your patients and depression that come in, but also in being reimbursed for providing that service. And this is just an example of the audit, which is the Alcohol Use Disorders Identification Test. And Lori's going to talk to you about specifics for billing, but this is a great addition to, you know, annual wellness visits or the like that you can you know, provide to your beneficiaries and all patients really. Once a year at least, so you can make sure that they don't fall into that category of you know, a fourth of persons with alcohol-related deaths. So right now we're going to put up a poll. It'd be great to see how often you were screening your Medicare beneficiaries, Part B beneficiaries, for depression and alcohol use. This is related to just screening, not billing. So you should have a little pop-up. So if you could please chime in there so we can see what everybody is screening in their offices. I'll give a couple minutes. It looks like the vast majority of you are 75% or more. That's great. And you know, it looks like at least three-fourths of everyone's over 50%. So that's good. I'll give you about another 30 seconds to allow people to vote in. Great. So I'm going to go ahead and end the polling. We have a pretty good response here, and it looks like, yeah, we're at over 50% are doing it 75% of the time, and over 3/4 of you are doing it over 50% of the time. So that's great. Okay, and I wanted to, before I let Lori take over, the last thing I wanted to kind of cover before her presentation is I wanted to let everybody know about the revenue potential in primary care for providing these annual screenings. So, if you, as you can see, the x-axis is the number of beneficiaries screened in a year. So the values here are 0, 100, 1,000, and the average in Oregon in primary care is anywhere between 200 and 500. So that's why I kind of chose these numbers. But you can kind of gauge where you are in between 0 and 1,000 on there. And then on the y-axis, obviously, it's the monetary value of reimbursement. So you can see, that how much you could possibly have in addition to your regular revenue. If you screened 100 patients for alcohol or depression, or alcohol and depression, you're looking at about $3,700, $3,800 a year. But if you times that by 10, if you're a slightly larger or provider's office, or especially internal medicine office, then you're looking at an additional $37,000 a year, and that's not really a chunk change. So so I hope that this graph can kind of put a light bulb off, and you'll listen to Lori with kind of this in the back of your head and how this can be implemented in your office.
That was where that version came in and scrubbed.
So right now I'm going to turn it over to Lori.
Doing a lot. Leaving money on the table when we're doing those. Others that we're still, I mean, I'm assuming because they're on the forms that they're still doing that. We're documenting those here.
Thank you, Chris. While we bring up the slides, as he introduced me, I am Lori Weber. I am a CPC coder and with the Noridian contractor for education. And for those states of Idaho, Utah, and Oregon, where we're residing today for our presentation. And I am just elated to be here and working with Health Insights and for Health HSAQI as well, and bring you this behavioral health screening slides. Have about 28 slides here today. And I just want to thank Chris and David for having me here today. So, okay. So hopefully all of you can see the slide that's showing up right now. And so the second slide we're going to show you is our disclaimer. We have these on all of our presentations, just letting you know that this is an as-is product and that things can change rapidly in the Medicare world. So we encourage you to sign up for our emails, be on our website, and the CMS website as well to keep up to date. Also, all the information I'm talking about today, we have complete presentations on them. So we have a presentation just for AWV, IPPE. We have them for the Correct Coding Initiative, CCI, MUEs. We have them for claims submission, appeals, anything you'd like. We probably have a webinar on that. So we encourage you to visit our website if you're not real sure what I'm talking about when I get to that slide. And so you are also welcome to copy this presentation when you receive it and share it among your colleagues. We just ask that you don't post it to any of your own websites or modify it.
The properties,
If we did.
And if you're not on self-mute, you might want to, as we can hear background conversations at this point. So appreciate that. Here, this slide is just some helpful acronyms to help you if you haven't seen these before. The CCI, CR, E&M, Face-to-Face, IOM, the Internet Only Manual, which is the Bible of Noridian Medicare and CMS, the place of service, and of course the task force, the United States Preventive Services Task Force. And I'll talk a little bit more about that in a moment. Give you a moment to peruse. Okay, so my agenda today just includes the 3 separate behavioral health screenings that Chris was talking about. We have alcohol misuse, we have the SBIRT, the SBIRT as I call it, screening, brief intervention, and referral to treatment. And then how does the annual wellness visit work with all of this? Are they able to be hopefully some valuable resources that you can take a look at later? And so we're on slide 5 here. Again, I want to reiterate that I won't be able to speak to the FQHCs and RHCs, but you are certainly welcome to stay and listen. CMS did set national goals to improve the behavioral health, and we really want to help those Medicare patients, our beneficiaries, specifically in the primary care settings. And of course, all of this is legislated, so that always depends on if it's going to be covered or not. And the screening benefits over the, oh gosh, it seems like it's been the last 2 decades, have been added to the Medicare program, as I said, through legislated action. And they came through the Medicare Modernization Act of 2003, and these types of benefits are covered if they're only covered if they're outlined by statute. So several screenings were added to detect diseases that were not diagnosed. So that's where it's important to know that it's the screening. They have not been diagnosed. And with early detection, we're hoping that the providers and the patients can prevent further issues, as is the goal of the QIO, the QINs. So the patient must not have any disease history, nor symptoms or signs, and no support from any kind of radiology or lab tests before this is started. And then on slide 7, this is where we talk about the USPSTF. What they do is their job is to improve health for all Americans. And they make this by using evidence-based recommendations with these preventive services, such as screenings that we're going to be talking about today. They were created in 1984, and they're an independent volunteer panel of national experts. And so they really have an important job, because they then make the recommendations to Congress and by providing their findings. And they'll give them an A or B rating. And that probably doesn't mean much to most of us, but what it also tells CMS is this screening or preventive service going to have co-insurance or deductible waived? So that's always real important, especially if you're a provider. You want to know, is that patient going to have any out-of-pocket? And sometimes they chose some of the preventive and screening services to have one waived and the other not. So it drives you crazy sometimes to look through this. But do be aware of that, and I'll have some resources at the end that you can check that out. And then many of these were also, because of the Affordable Care Act, were also created or approved for payment. Okay, so now we'll start with our first screening, alcohol misuse. I think I have about 5 slides. And with this screening, all Medicare patients are eligible. And what I mean by that is, it seems that all screenings, everyone should be eligible, but there are some of them, not in today's presentation, but there's some of them that you have to have this, to have that. So that's why I say all Medicare beneficiaries are eligible for the screening, meaning there's no age requirements, etc. G0442, a HICS code, is your annual screening. This can be done every year, And it says 15 minutes on the code, but that means up to 15 minutes. And then what happens is if that screening is positive, then you can actually provide up to 4 counseling sessions in the next year. So that's really, really important that you have all that information so that you can also provide those, and they'll up to 15 minutes as well. So co-insurance and deductible are waived, as you can see here. And then in the last bullet, you may not know, POS place service. And what that's saying is it's usually in primary care settings or office, outpatient hospital, independent clinics, and your public health clinics. Now I know it's also in the, the FQHCs and RHCs, but just for today's purpose, I didn't add that in. So,
Lori, we had a question come up that I thought you might be able to address. So someone wrote in and said they're a pain management group that does see a lot of Medicare recipients, and they do perform these services, and they wonder if there are limitations if they're performed by both primary care and their practice. And similarly, a primary care provider wrote in and said if these are done in specialty, who gets paid if sort of they're both doing screenings?
And that is a great question. This is only covered once per year per patient, correct? So what we encourage, and I was even going to talk about that at the end, is that you're signed up with the Noridian portal because you can check eligibility. And that's really, really critical because you don't, it's just like a flu shot. You don't want to give the patient a flu shot. They already had one. I don't know why they didn't tell you, but they already had one, and now you're going to get your claim denied. So eligibility is really, really critical in this matter. So it doesn't matter to us if it's necessarily the specialist or the primary, care. It just has to be one or the other.
And then one other quick stop over question. Does up to 15 minutes mean 8+ or 15 minutes?
It's just up to 15. Now, usually with CPT codes, and this is a HCPCS code, CPT codes are at least half, and so 8 would seem, that would seem the norm. So I would just say 8 to 15.
Great. And then we have a couple of others, but we'll hold them for Q&A.
Oh,
yeah.
Great. Thank you very much. Yeah. Great questions, everyone. Okay, now we're on slide 9. Now, counseling. So I'm going to talk a little bit about that. It's furnished, of course, by the primary care practitioner to the patients. And I say practitioner because, remember, it could have been an MD, it could have been a practitioner or a physician's assistant, even the non-provider practitioners. So, and the patient has to be competent and alert at the time. That's one of the critical elements. You need to identify that there's someone who misuses alcohol, they want to quit, but they don't have the levels of alcohol consumption that would meet dependence. So you want to look at some of that criteria, meaning are they going through withdrawals? Are they, that would not be where you would want screening. You can already tell that your patient is in that population. So what we call risky or hazardous drinking, CMS defines, and it's not on the slide here, but I can certainly add it. I'm sorry, I'm hearing some feedback, so if you wouldn't mind or 3 drinks per occasion. And for men, it's over 14 drinks per week or 4 drinks per occasion. So if you want that information, I'll make sure to get that on here. And again, I'm talking about the Noridian portal, which has patient eligibility, claims, claims tracking, appeals, everything. And we have a complete portal presentation if you're not aware of all the functions that the portal has. So I didn't want to go into that detail today, but unfortunately, they don't have the G0442 and 443 yet. So we're working on that, so please stay tuned.
Lori, one quick question that's applicable to what you just shared. It says by a qualified primary care physician or practitioner. Does that include psychologists or social workers who might be part of a primary care team?
It does not. It does not. So unless you can perform that as a incident to, meaning the physician, what they call direct supervision, the physician has to be in that clinic at the time. Does not have to be in the room, but does have to be in the clinic. But they could not bill direct.
Great, thanks. And any of the folks that, when we're stopping for your question, if you have a follow-up, go ahead and send it in. If we don't get to it right now, we'll try and do as many as we can at the end. Thanks.
Oh, appreciate that. Okay, then these next couple slides are talking about the 5 steps of counseling, what they call the 5 A's approach. Slide 10. And I'll just give you I'll give you a moment to read the descriptions, but basically you want to assess their risks and their behaviors, you know, using the forms and stuff that Chris went over, or create your own. We don't have any of our own at Noridian. And then making sure that you're advising them what's that personalized behavior change that needs to happen, you know, what are the benefits, what are the harms, if they keep going forward. And both have to agree, both the patient and the physician need to collaborate on what are those treatment goals, what are the methods to be looking at. And then for 4 and 5, on slide 11, we have, you know, using those change techniques like self-help, maybe aiding that patient to acquire other skills, giving them goals to support the behavior change. Maybe even medical treatments are appropriate. And then, of course, lastly, you need to schedule either follow-up or I guess I should say, follow-up either by telephone, in person, provide that ongoing support and assistance. And then you may even come up with some kind of a treatment plan. And they may need to be referred to another entity that gives them specialized treatment. And so here's the slide that gives you the eligible providers for the G0442 and 443. And as you can see, it's basically all of your general family practices, your internal medicine, geriatric, and as I said, NPs and PAs earlier. And Medicare will deny claims if any other provider specialty bills. So you want to be very careful about that. And then on slide 13, we have, we're going to change gears here for the next couple slides. We have depression screening. And you might see at the top NCD 210.9. That's our National Coverage Determination Policy, or NCD 210.9. And this is going to involve HCPCS G0444 for the annual depression screening. Again, like the last alcohol misuse, we have up to 15 minutes. We don't have any specific screening tools, but utilize your QIOs to help you with that. And of course, you can check to see if the patient has already had this in our portal. Co-insurance deductible are waived, and it was asked, can we bill the annual wellness visit the same day as the depression screening? For the initial, no. And the reason is that there's already an element of depression screening in the initial AWV. But for the adult, you can. So there in the 4th bullet, you'll see in the sub-bullet, established is yes. So year after year, then you can bill the AWV with the depression screening on the same day.
One quick question before you move on. There's been several questions about the sort of provider eligibility, and they want just clarification on what you said, because there was a couple of slides back, maybe lists of provider types, and so folks weren't seeing the professionals that are usually a part of their behavioral health team on that list. But you said if one of these eligible providers is in the practice and someone else is doing the screening on their behalf, that is acceptable. And they just wanted to clarify that.
As an incident too. So they would not be doing the billing, the MD would still be doing the billing, but it's possible that they could perform that incident too. And what I'll do for everyone, since this seems to be a big question, I will get some more details and we'll get that crafted into an answer that really explains all the details, if that's okay.
Great, that's wonderful, thank you.
Excellent. Great question. And then, I just wanted to say on that last slide 13, it said per CCI. That was one of our acronyms, Correct Coding Initiative. That's because if you go out there and you type in those codes, they will bundle with each other. So whenever you see a 0 on CCI, and that's a whole nother presentation, you cannot unbundle and you cannot bill Medicare or the patient. So I just want to make that clear, that the patient cannot be billed in those cases.
Another quick, just because this has come up a couple times, are there specific diagnosis codes to use when doing both services, the annual wellness visit and depression screening?
Great question. No, it's like one of those that that I'm aware of. You know, you just use something that makes sense. I mean, we wouldn't want to hear, you know, they had a hip replacement or something, but the screening should usually be able to be billed. Again, I'll take that back because it looks like that's a question that a lot of people ask. So I'll ask about if there are any diagnoses that we prefer in our system. So good question.
Yeah, no, that's great. Thank you.
So kind of piggybacking on what Chris said before, it's estimated that 1 in 6 patients over 65 years old suffer depression. I thought this was such a high amount. And then when you said the 23%, it just really, it's the highest risk of suicide of all age groups as well. So coverage is limited to the screening services, and it doesn't include any kind of treatment options. We're not looking at complications or chronic conditions in these codes. That doesn't mean that Medicare doesn't have other codes that can be billed for that, but just not with these screening codes. It doesn't address, these screening codes do not address therapeutic interventions like pharmacotherapy and combination therapies, including any kind of counseling, except for the actual codes that are chosen for that. And then at a minimum level, you can have staff-assisted care support that may consist of a PA or a nurse practitioner, and of course your clinical staff like your nurse. They can certainly advise that physician of the screening results and also facilitate and coordinate referrals. And under this definition in the last bullet here, these place of services are not considered primary care. So you have your ambulatory surgical centers, your ASCs, you have your independent diagnostic testing facilities, your IDTFs, skilled nursing facilities, SNFs, and hospice, and emergency room departments, and inpatient hospital, rehab facilities. Those are just not a place where these screenings would be taking place.
We do have a couple place of service questions. So in a rural health clinic, place of service 72, and then there was one about whether these are allowed in an FQHC place of service 50. They didn't see them on the list.
That's because if you heard in the beginning, we have kind of a disclaimer that this will not be addressing rural health clinics or federal qualified health centers. I'm really sorry. That is more for the Part A side. Even though you might be billing Part B, we were not going to address that today, but I'm sure that your QIO can help you with that, or, you know, I can certainly find out and add that to the Q&A. So great.
Yeah, so we have email addresses for everyone today in the chat transcript, so we can follow up with you individually on those questions.
Great questions.
And then there was 2 others just on on when you say depression screening can be billed on the same day as a subsequent annual wellness visit, do you mean when it's performed as part of the annual wellness visit, or if they see the provider separately from the annual wellness visit on the same day and have the same service performed?
Either way.
Great.
So I would think your patient wouldn't want to come back in the afternoon if they saw you in the morning, so I would think it would be at the same time, but if that's how it runs, that's how, that's fine.
And then when you say annual depression screening, does that depend on the last date of one performed, or does it renew at the beginning of the year?
No, it's at least 12 months have passed, or sometimes you'll hear at least 11 months have passed. It's, we just know that everybody doesn't run on the calendar basis. Now your allowables might be running on our calendar basis as our fee schedule is, but as far as, the time factor, you'll have to go with whenever the last visit was.
Great, thank you.
Good question. Okay, so now we're on slide 15, and how are we doing for time? Oh, we better get going here. We're only halfway through. The next couple slides are screening, brief intervention, and referral to treatment, or SBIRT. So this is kind of in that alcohol type of treatment. It also includes other problematic disorders for other substance abuse, everything but tobacco. So you may have some others that go into this. So it's community-based screening for some patients that are designed, are the patients that identified and we want to reduce and prevent their problematic disorders. You would use them in the primary care settings again, and it's for those beneficiaries who may not seek help for their substance abuse problem. So there's a host of providers, as you see here. Many of these are these are just pretty much the same ones. And your documentation, I know this was a question, it needs to give the start and stop times because these are 10 days codes. So you do want to put that in there as well. Again, this one is a 15 to 30 minutes. And then if you need additional time, you can add the G0397. But please make sure that is supported in documentation, just in case. So the difference between the alcohol misuse screening and SBIRT is this one's actually treating the issue for most of those substance abuse patients. And then on 16, I have some early intervention approaches to look at this where they need more extensive specialized treatment. It's really like three major components that we're looking at: screening and assessing the patient for any of that risky substance abuse or substance use behavior. You can use standardized assessment tools, brief interventions that you're engaged with, short conversations with them, providing feedback, motivation, advice, whatever it may be. And that can consist up to 5 counseling sessions. And then the treatment, maybe it's a referral to therapy or something else that you would need an additional purpose. And then here's the fact sheet from CMS. It is dated clear back in March of 17, but it is still current. I checked yesterday. Has about 11 pages in it. And it's found in this link in the first sub-bullet. And then it includes documentation needs, how to bill both Medicare and Medicaid eligible patients, or what we call dual eligible. And it may also be provided via telehealth. So that's a whole nother world, which we have a complete presentation on that as well. You do have to meet all those requirements, and those are pretty detailed. So you want to look at our publication here. It's called the Medicare Learning Network product, and this is in the last sub-bullet from CMS. And so now we're going to move on to the annual wellness visit. I'm just going to give a couple brief slides. I think I have about 4 of them here. And are we okay for questions? Great. Okay, with both G0438, which is your initial, the once in a lifetime, and the subsequent annual G0439, there's no specific diagnosis codes here either, and just bill the most appropriate. Like many other Medicare screenings, the deductible and coinsurance are waived, of course, performed by most health professionals. Now, with the AWV, that also can include the certified health educators, the diabetic educate, the registered dietitians, nutritional professionals, and those licensed practitioners, or from the team of medical professionals like the RNs. If their state scope of license allows, that's always the underlying, well, is make sure that state scope of license allows you to perform this, these different screenings. And then the MD has to be there for direct supervision, as we talked about earlier. So here's the initial AWV components. I was just going to go briefly over the list. In the green here, you'll see obtaining the beneficiary history, the health risk assessment, establishing a current list of providers, reviewing all those risk factors, including current and past experiences, review their functional ability, their level of safety based on direct observation, or maybe you're using a screening questionnaire. And then in the blue here, you see the assessment. You want to obtain the measurements, let's say the height, weight, maybe body mass index or waist circumference, depending, their blood pressure, all of that. Routine measurements is deemed appropriate for their personal and family history. And does the patient have any cognitive impairments? And then in the purple, the third component is counseling that beneficiary. Maybe you have a written screening schedule, a risk factor list, any kind of other conditions. And then the next slide just goes into the subsequent components, pretty much the same as the initial, except you're going to update all that beneficiary information assessment. So this one, I'm going to just make a statement here that's not, I think many of you that are in this world know that it's confused a lot with the routine,
Dr. Tillis?
routine annual visit and the routine annual physical, I should say. And that is just, that's the 99,300 codes. Those are never covered by Medicare. So what you will traditionally do is carve that out. You'll have the AWV-G code, you'll have the 99.3 code that the patient is completely responsible for. And then if they come in with any other problems and issues that meet an E&M, an evaluation and management code, you'll use the 99.2 appropriate code with a modifier 25. And we talk about that in the AWV presentation. We know it's been confusing. Okay, now how to prepare. I would have, help the beneficiary prepare for their initial one. Have them bring in, their list of prescription drugs, over-the-counter drugs, vitamins, supplements. I mean, of course, you can have them fill it out when they come to the office, but sometimes they don't recall everything. So it might be helpful if you don't have all this information, including family health history, to have them bring that in. And also all the current providers that they work with. Who do they have? A podiatrist? Do they have a mental health facility, physician or psychologist, psychiatrist? And then here's the CMS checklist and the link below if you'd like to take a look at it in more detail. Just kind of letting you know who, what, have I done this? Have I, is my patient, do I need to screen them for cardiovascular? Even though we're not talking about all these other screenings today, I just thought this might be helpful. And then I think this slide is probably one of the most important slides of today because I know it gets confusing. Can I build this with this and that? So I just put it here and hopefully I'll make sense here. Same day, same patient. AWV can be billed. It is allowed with the 396, the SBIRT, also the alcohol misuse, but it is not, remember, with that initial depression code. But it is with subsequent AWV can be billed with the depression code. And then over on the right side, just letting you know that the portal has these eligibility searches for AWB and depression, but unfortunately not yet for alcohol misuse and SBIRT, but stay tuned. And then in conclusion, to summarize this, here are the links to the Noridian Medicare jurisdictions, depending on what state you're in, the JF or JE states. And like I said before, we have so many different presentations that go into more details. So if you want to look at some of those Adobe PDFs, there's also Q&As out there that may answer your questions, then please feel free to go out there. And now just a couple slides on resources. And so these are the internet-only manual references. These are great if you just have all the time in the world, which I know you don't, but you can at least see some of that information right here, along with that policy, that national policy that I talked about earlier. And then here's another very important slide. If you've never seen this before, it's the links at the bottom, and it gives you the complete preventive screening chart. You just click into the box that you have a question about, and it's going to show you if there's a diagnosis, insurance deductible waived, who's eligible, who can bill, who's the providers that can bill. It's going to give you the codes involved, the frequencies. It's just great. And even sometimes payment information. So with that, I thank all of you for coming today. And thank you for your time, and we can now move on to some questions.
Great, we have a number of questions that I've been holding to let you get through, Lori. And again, folks, we have the chat transcript, so if we don't get to your question today, we can follow up. So first was, how long between an IPPE and the first annual wellness visit is required?
Again, that is another 12 months. So the IPPE, for those that may not know, is that first welcome to Medicare visit. So that's going to happen. That needs to happen within the first year that the patient becomes a Medicare beneficiary. And then, of course, you'd have to wait another 12 months.
Great. But thank you, Lori. Before we move on to your next question, since we have so many great questions that I want to make sure everybody gets a chance to ask, I just wanted to let you know about some resources that we do have attached to the recorded webinar and the slides that will be given to you. And these are, this first slide here is they're both workflows, these last two slides. One's on paper billing with a high rate of revenue return. And the second one is using an EMR to its fullest potential. So using your electronic health record and having everything be automated. I put together these workflows based on a couple Oregon clinics that are really doing well, up to and greater than 70% rates of billing for their alcohol and depression screenings. So again, these are available on the slides. I wanted to make sure that we covered as many questions as we can. So let's move on to the next question.
Yeah, so an easy one. Yes, the information will be emailed to you with slides and websites and links and all that sort of good stuff and the items we said we'd follow up on. Someone asked, are we able to call Noridian and check to see if an alcohol screening has been performed? You said it wasn't part of the portal, but are they able to call and ask that?
You might be able to. We have the IVR system, the interactive voice response, but that's something I'm going to have to find out, because I would think if we had that information without doing a lot of, that we would put it on the portal, because, so I could be wrong. So let me check on that for you.
Great, we'll check on that. And then someone asked, can we bill expert if it's negative? Our Medicaid program has stated that only positive is billed. And there were a couple of people who had that question.
Oh, okay. I don't know. So okay. I'm going to check on that as well.
Okay, we got to the hard one.
I didn't think that mattered to us, but maybe it does.
All right, so we'll check back on that one. Good question. Can you bill an annual wellness visit with an office visit code on the same day?
Yes, and that's what I was alluding to earlier, where the patient comes in for the routine physical. So that's not covered by Medicare, but the AWV is. And if they come in, let's say their diabetes is really off whack, or their high blood pressure, that takes an E&M visit. As long as you meet all the criteria, then you can bill the 99 something for the E&M. Just make sure that you do append a modifier 25.
Okay, and then there were some questions about whether RNs and then other folks, I think it was medical assistants or CNAs, can bill for expert and an annual wellness visit when under the direct supervision of the physician. So I know you said that, you know, we follow up with information about who can do what, but I just didn't know if you had any.
I've never heard the CNA question, but I thought RNs and MAs could under the direct supervision. Again, I think it's a really good idea for me not to do a verbal, but to really check this out and give you some detailed answer.
Yeah, so it sounds like a lot of people
Great
are
questions.
implementing team-based care models in their clinics, and so they really want to you know, make sure everyone's working to the top of their license. We're going to pop a survey in here. Please take that survey. It really helps us to know what you thought of the webinar today. So that's in the chat for everyone to fill out before they sign off. I think we had a few other questions, but I think they're all ones that kind of fall into the bucket of following up afterwards.
Great. Thank you. Thank you both to Kate and Lori, also to Dave. And I just wanted to give some contact information for anything that you don't receive from us and answer these questions or go through the survey, which please, again, take the survey. It's really going to help us out moving forward, both with future presentations to everyone and also the education provided. Here is my personal office phone number. And you're more than welcome to reach out to me anytime. Also, our Health Insights website and my email address are both here. So if you need anything at all regarding behavioral health or any of the other tasks that I mentioned in the beginning, then please reach out and we can get you some help, especially like Dave said, also around the quality payment program where you take care of that for the state as well around MIPS. So if you have any further questions, please email me. And also if you're in HSAG's region or another QIO's region, you can also reach out to them and they'd be more than happy to help you with what you've heard today. So again, thank you for everyone for coming, and I hope you got something out of it. Please let me know officially whether you did or not by taking the survey, and I hope you all have a very pleasant day. Thank you.
Thank you.